I have about an hour, and we're going to go too fast, and we're going to cover a lot of areas. So a little bit about technique before we get into too many pathologies. How do we do pelvic MRI? Well, you can do it in multiple different ways using different coils. These protocols, or this approach is pretty standard for 425 Tesla magnet. We like to use what we call a multi-coil array, which is a wraparound coil, a diaper coil. There's two different varieties. There's one called pelvic and one called torso. Sort of depends on what your hospital has decided to get. But the best thing to do is to use one of these rather than using the large body coil, which is, of course, the magnet itself. Now, why do you want to do that? Well, it allows you to do the zoom lens thing, to sort of talk your field of view, get in close to the area of interest, and allows us to increase the signal to noise without decreasing the quality of the image. Protocol's fairly standard, nothing terribly fancy here, nothing really sophisticated. We're doing lots of T2 images. A lot of multiplanar T2 is the key in the female pelvis, male pelvis. You want a lot of those. We're using more and more gadolinium, particularly in malignant diseases. We use it in the dynamic mode, same protocol as we use for the liver. So fat suppressed, radiant echo acquisition, start off with a non-contrast and then run it a couple of times afterwards. And so you get the multi-phase approach. We do some short axis views and oblique things when we're looking for congenital anomalies, but that's basically it, so it's a fairly straightforward protocol. What does the normal pelvis look like? Here's some views. This is axial, this is sagittal. This one obviously is remarkable that the uterus is flipped backwards and so it's retroverted. The uterus itself has multiple layers, as you know. Important to understand the normals before we look at the abnormals. We have the outer serosa. We have the thick one, which is, of course, the myometrium. We have a basal layer of the myometrium, which is the so-called junctional zone. That nice, thin little black guy right there. It's the hypoechoic area on ultrasound. And then we have the central stripe, or the endometrial cavity here. And then the ovaries, of course, nicely seen off on the side here. Cervix, a little bit different. You can see the cervical anatomy. There's the internal os and the external os. Here we have it at the vaginal level where we see the cervix surrounded by the vaginal fornices. That can confuse people quite a bit because it looks bulky. It really confuses people probably more on CT than it does MRI, I hope. So multiplanar capability is critical for delineating the ovaries and finding them. Sagittal view I like because you can find it in a nulliparous woman. It should be under the bifurcation of the iliac vessels as they become the external and internal iliac. That's where the ovary starts off in life. Of course, as postpartum patients or women, the ovaries really can be anywhere up in the pelvis, so you'll have to look all over the place. But sagittal is a nice way to find it. Gadolinium enhancement patterns, an important thing to know. This is the same as it will be on CT, and we're doing CTs finally a little bit better in the pelvis than we used to. So we're now getting these kinds of images almost, and we're not quite in the pelvis, we'll never be quite there, will we? But CTs, with the bolus of contrast, you can really begin to see the differential enhancement between the cervix and the uterus, between a fibroid and the myometrium. So if you go in early, 20 seconds after the injection, the only thing that will light up is the myometrium. It's the most vascular thing in the pelvis. And so it'll light up immediately. Your cervix will fill in much later on because it's fairly fibrotic. Think of what the tissue is made of. It's hard. It's relatively avascular, so it will fill in slowly from the center outwards and from the outside in. And it's a hollow canal, so the luminal portion will enhance first. The vaginal walls, of course, also enhance before the cervix. Spirals are pelvic CT, pretty much usually done as an add-on to the liver, and so we really don't get a chance to optimize pelvic CT very much, but certainly now that we're doing more and more multi-detector, coronal imaging, CT urography, I think we're finally beginning to get a chance of looking at the pelvis a little bit better. We used to in the old days when we couldn't get down fast enough with the bolus. We used to have a dedicated protocol where we would scan from the symphysis upwards, and that can be helpful if you're interested in doing that approach. But now most of the time it's not necessary. One thing that's critically important in pelvic CT is really to use oral contrast material. It sounds so basic and so obvious, but unfortunately it's rarely done anymore, and pelvic CTs really suffer because of that. And because we're using water and all of the other lack of iodinated contrast materials in the pelvis now, I think we're running into more and more trouble, and that's where MRI, again, is obviously extremely helpful. But this case, for example, what is going on here, we've clearly got IV on board, we've got cervix enhancing in the center, and we've got these cystic areas within the pelvis. And when you give the rectal contrast, you can see clearly that there's nothing bad going on here. This is just unilocular bilateral adnexal cysts. And so oral contrast is critical. If you can't get it in orally, you have to try rectally. This is a case I'm going to come back to, but this is an example of a recent case from our hospital where patient came in to evaluate a known pelvic lesion, came in for staging CT. And these are the kinds of images one will typically get when you've spent your time looking at the liver and you come down into the pelvis. And the question really is here now, what is going on with this mass? This patient is about to go to surgery. In fact, I believe went to surgery yesterday. We're going to come back and see her MRI in a little while, but I want you just to look at this and think about what the CT is showing us here, and really can we tell very much of anything? Is the bladder invaded? Is the rectum involved? Where is this mass? And it's not necessary to make the diagnosis histologically, but the CT here is for staging purposes. So let's just go now through some of the common reasons why we do pelvic MRI first. One of them is these llerian duct anomalies. And hopefully you're familiar with the classifications, but these are the list of them now, and they're classified according to the American Fertility Society as 1 through 8, 1 through 7, as you can see here, through agenesis being number 1, unicornuate uteri, where only one system has developed, has a bunch of different varieties. Obviously, we all remember that unicornuate means single horn, and one system is good, but that's really not the issue. The issue for us is to find out, does she have any of the variants? Does she have or does she not have a rudimentary horn that may be present? And if there's a rudimentary horn, does it or does it not contain endometrial cavity? And if it contains endometrial cavity, does that with the other system? And so there's a multi-layered analysis to go on here beyond just thinking you're great by making the diagnosis of unicornuate. You're not done at that point. You need to go all the way to the end. Because if there's an endometrial cavity that does communicate with the other one, that is a focus for an ectopic pregnancy to be implanted. And this therefore implies that the rudimentary horn should be removed and surgically removed. And so you need to guide the surgeons into that. This is, of course, the classic one we all remember from med school, where nothing gets fused and everything's duplicated right down to the middle of the vagina. Bicornuate and septate, two groups that we get asked quite frequently to distinguish. The bicornuate is closer to the didelphys, it's further apart, the angle of obliquity is wider, and there will be an external cleft between the two horns. Should be greater than 2 centimeters. Septate, almost everything is fused except for the septum. The septum has not been resorbed, and so you have to find that. This is the most common cause of early pregnancy loss. So septate is important to diagnose. It is the one that they will operate on. Most of the others nowadays are not operated on. The didelphys is not, bicornuate is not. Arcuate and the DES, remember that they're in this group, but neither of those are surgical cases. So let's look at an example of a uterus didelphys. The first thing to remember is always, of course, image the upper abdomen. You must look to see if there's an associated genitourinary abnormality. The most common will be renal agenesis. You can see here on our MR, which is part of our protocol, large field of view coronal, we're missing a kidney on the right side. And as you will see, let's bring them all up. Actually, wait a minute, let's just go back. So on the coronal T2 here, now we can see that we clearly have 2 uteri way off to either side of the pelvis. You can see our classic zonal architecture, myometrium, junctional zone, endometrial cavity sitting here, and we see another one here. These particular cases really need a lot of images, so a little bit hard sometimes to show in a session like this, but you need to use all your images to make sure you look carefully for this classic appearance of a uterine horn. And then if we bring up the next one, you'll see a little bit further down on a coronal plane, we see very nicely the sort of parallel channels of 2 endocervical canals. And this is your classic 2 uteri, 2 cervices. And then you can see it again here in long axis, and then in short axis, the double barrel, basically, of the 2 cervices. Here's an interesting one, too. I've got the answer here. I should have put it on a fly-in thing. But 15-year-old woman, young woman, with a painful right pelvic mass. And you can see here, I hope, on this oblique view, that we have the classic banana-shaped uterus. That is our unicornuate system that is normal. We have another system over here which is suspended off the side of the body of this uterus. It was isolated. It did not communicate with anything. Multiple images failed to reveal a cervix or a vagina attached to that. And so as you can see from the answer down here, this represents the rudimentary horn of a unicornuate system with a non-communicating rudimentary horn, no endometrial communication, but she does have endometrial cavity within that, and she does therefore have, as it turns out, anomyosis in this rudimentary horn, and that's why she had such pain, of course, with menses. And another one, hysterosalpingography is the gold standard test for tubal patency, as you know, and hysterosalpingography is done frequently at our hospital with our infertility clinic patients. And you can see tubal patency on only one side here, but it's slightly strange-looking uterus. Could be described as a banana and maybe a unicornuate uterus, but the question really was, is it or is it not? MRI shows it's not, but let's go back just for 1 second here. What were the tip-offs on this? Perhaps slight irregularity here, and the fact that it's not a very skinny, smooth little banana-shaped unicornuate system going off to the side. But remember that this can happen easily in a septate system where the cannula gets put into one horn. The septate uterus here, as I already said, is almost normal. The uterine size is like one uterus. We've got a flat outer, basically everything has come together and fused. The angle of divergence of the two canals is extremely narrow. If you like numbers, that should be less than 75 degrees. So that tells you that it's a septate uterus. You're not done at that point. The surgeons then want to know what is the septum, what's it made of, is it fibrotic tissue or is it myometrial? So you tell them how much is fibrotic and myometrial. This stuff can easily be removed. This cannot because it's obviously very vascular. A little bit about the role of imaging in MR and CT and fibroids is really not to make the diagnosis. The diagnosis is made clinically on physical examination and very frequently on ultrasound. The role of MR in particular is to confirm that diagnosis. Because adenomyosis, as you know, is frequently confused with leiomyomas, the same presentations, a little bit older, of course, that is the patient. And of course, in physical examination, both the adenomyotic uterus and the leiomyomas will feel the same. First, confirm the diagnosis that we have fibroids. Then our job is to define the number, the location, and the size. So you go through an algorithm where you define exactly where each one is. And this is getting to be more and more important because we're doing many more different types of treatments for leiomyomas, and they depend on the number, the location, and the size and type of fibroid, as you'll see in a second. We need to help differentiate this from big masses. Is a pedunculated fibroid or mass, for example, a common dilemma? Adenomyosis, as I've mentioned. Our role is to assess the vascularity and the presence or absence of any degeneration within the leiomyoma itself. And so as you can see, the whole overall perspective here is changing. We're getting into more detail. You can't just say fibroids, next case. There's a lot to do with MR in fibroids, and we must look at vascularity degeneration. And for that reason, we now give all intravenous gadolinium when we're scanning them on MR for fibroids because we're particularly interested in degeneration. There is no point in doing uterine artery embolization or other treatments if the fibroids are completely necrotic already. If they've already outgrown their blood supply, you're really not going to do a lot by embolizing them further. You're just going to cause myometrial infarction, a lot of pain, and probably not a lot of symptom improvement. Degeneration also we'll come back to a little bit in a second. And so treatment planning is really our major role. Let's look at some cases. Here's an example of a patient who was pregnant, and she's got this very large, slightly heterogeneous leiomyoma. The classic ones are homogeneously low signal on every pulse sequence. They're usually very black on T2, cookie cutter sharp borders. This one has what's known as hydropic change or change of pregnancy. Because of the stimulation of the hormones, the fibroids look different in pregnancy. They behave differently. Some of them can grow very rapidly with stimulation, so it can be a major issue in pregnancy. Clearly, first of all, in viability. Secondly, in delivery of the fetus. And so it's important to get a baseline and to understand the size of these early on in pregnancy, and that, of course, usually obtained from ultrasound, and MR plays a role after that. Here's a complex pelvis where you see lots of stuff going on. There's only one view, but believe me, there's the outer edge of the uterus here. Here's the endometrial cavity, and there's that junctional zone. There are multiple fibroids here, and there's a big cystic degenerated one over here. Now, how do we know that's a fibroid? I'll show you in 1 second. Before I give gadolinium, there's a differential diagnosis where we can decide what this is. We've got a large, complex mass living in the right adnexal area. It contains what we think is fluid on a T2 weighted image. It contains what we think might be solid areas, septations, and a thick wall. So all those are buzzwords for an ovarian neoplasm. And so that's clearly on our minds. When we give the gadolinium, we can see that this belongs to the uterus. It's covered in myometrial tissue. and so that becomes a degenerated, cystic degenerated leiomyoma. This is not one that would respond well, therefore, to uterine artery embolization or even focused ultrasound. This is the biggest one in her pelvis, and it's clearly already outgrown its blood supply. The other differential diagnosis, of course, with fibroids is this, which on hysterosalpingography shows evidence of the cavity being filled, one tube just about opacified here, and multiple branch-like structures filled with contrast. Anybody? You're all asleep. And you're enemy. Adenomyosis, great. Somebody said it. So this is adenomyosis, of course, classic appearance. You don't see it on hysterosalpingography too much anymore, but these are the pseudodiverticuli, the contrast as it's going out of the endometrial cavity. Adenomyosis, as you know, is ectopic endometrial tissue in the myometrium. Endometriosis is the same disease, but the tissue is now ectopic everywhere else in the body except in the myometrium. So the same disease, different names. This is what it looks like on ultrasound, where we see this diffuse hyperechoic thickening of the wall of the myometrium here. And this is what it looks like on MRI. This is a cropped coronal view. You can see bladder here. This is uterus here. And this is the junctional zone, just a tiny bit of it that's normal. That junctional zone is the basal layer of the myometrium. So the first layer to be penetrated by these burrowing endometrial tracts. And so what happens is that the junctional zone thickens right up, and you get these punctate little dots of high T2 signal tissue out in the myometrium. And that's your classic appearance of adenomyosis on MR. Atypical leiomyomas can look like this. On T2, we start off looking fairly normal. We've got a large, well-defined, low-signal T2 mass in the myometrium. Another one here, T2. And there you've got a submucosal one. But then we go to T1, and we see this really high signal stuff. And we begin to think this is not a fibroid after all, maybe. Well, this is the classic appearance of what's known as the red or carneous one. This is red or bloody hemorrhagic fluid on a T1 weighted image. And it's necrotic already, it's degenerated, because after we give the gadolinium, we can see that this is not enhancing. So again, another case that would not respond to uterine artery embolization or focused ultrasound. This, by the way, is the appearance you see very frequently after uterine artery embolization in someone who had a very viable, perfused one initially. So this is the appearance that you'll see of that hemorrhagic infarction in the post-UAE setting, which you will see more and more referrals for because they do or do not respond initially, and that they can have a larger mass effect. They can persist with their symptoms if the hemorrhage is not resorbed and the fibroid doesn't shrink. So this is an appearance to be aware of and to remember in the post-UAE. And once you see one or two of these, they all start to look the same. T2, T1, T2 on the left shows you the uterus up here, this big subserosal fibroid at the back, low signal predominantly, and then high signal on T1. That's another hemorrhagic one. A new thing that we're now doing, which is to ablate these using ultrasound. So you will hear a little bit about this. I just wanted to touch on it very briefly. MR-guided focused ultrasound surgery, using ultrasound to cook the tissue, to bring it up to a high temperature and induce thermal coagulation, is done now through MR guidance using the table in the MRI scanner like this, with a transducer placed over the woman's pelvis, using MR imaging to target and direct the therapy. This is a pre-treatment image where each little green circle represents an individual sonication or pulse of ultrasound heat into the tissue, short axis, long axis. These are temperature images acquired by MRI in real time at the time of sonication. And these give you immediate feedback that you have, in fact, elevated the temperature at that spot. And that's absolutely critical and one of the most unique features of this form of thermal ablation. RF ablation under CT, any other form of ablation does not have this yet. Cryotherapy does have it under MRI guidance, but not anything else. So this is one of the nice, very unique features. Instant feedback, you know that you've got the right temperature. If you don't get the right temperature, you can do things like increase your power, redo it again, and get it up there. This is what you see on your post-gadolinium image, and this is what you see on pathology. Post-focused ultrasound imaging, you may see these, even if you're not actually doing focused ultrasound someday. So post-necrosis, you can see these little black holes, depending on the volume of tissue that was ablated at the time of the treatment. One thing I would caution you about if you're doing pelvic ultrasounds is to really try to look back a little bit. I know this is very difficult because every other woman has a fibroid uterus, but this is an illustrative case where you can see two ultrasounds in the same patient, performed in June '03 and November '03. First one clearly demonstrates your classic big, bulky fibroid uterus, fairly heterogeneous, but an echogenic. But look at the difference over the less than 6 months here. We have now developed a bigger fibroid. We've got a lot of necrosis going on here. She was about 48 years of age, if I remember correctly, and she came to us because her fibroids were rapidly changing in symptoms. She was getting much worse. She wanted a treatment like uterine artery embolization or focused ultrasound. We did an MRI on her, and we decided definitely she should not have either of those treatments. Here you can see the fibroid on T2 weighted images. It's inside the uterus. It's fairly heterogeneous. We go to T1 pre and T1 post contrast. She's obviously lying on her back. We've got a fluid level or a hemorrhagic crit level almost in here. We have enhancing tissue afterwards. And this is very atypical. And so at this point, I think the best thing as a radiologist we can do is to talk to the surgeons, perhaps get on the telephone rather than saying this in your reports. But this is not someone who should be treated with a minimally invasive treatment. At this age and these dramatic changes, she needs to have surgery. This was a leiomyosarcoma. There are no typical features on imaging for leiomyosarcoma. There has been one paper recently written about MRI saying if we have a high percentage of T2 signal, greater than 50% high signal on T2, and equally greater percentage of T1 signal that's high, and that enhances after the injection of gadolinium, that these three features indicate non-benign fibroids. It's only one paper. There's not enough data to say those signs are 100% reliable. And as you know, leiomyosarcoma degeneration is extremely rare, less than 1% of all fibroids. So we clearly don't want to be going out there and causing a lot of panic. But when you see something like this, do get on the telephone and chat with the gynecologist a little bit and say you're concerned. And particularly if you were reading the second ultrasound and you saw such a dramatic change, I think that would be something to do. All right, let's change gears into the adnexa just a little bit. What are the features? We've already talked a little bit about masses in the adnexa. Ones that you start to worry about. This list came from a manuscript that was written saying that if you had 2 or more of these, it was a malignant mass. And that isn't, of course, true, unfortunately, but I do use it because it gives us a nice feature analysis approach, a step-by-step thing to go through when you're looking at adnexal masses. And you can see here, we worry about large ones, we worry about solid ones, ones with thick walls, thick septations, vegetations of nodules, a really good sign. Solid tissue growing on the inside of a cyst, and clearly necrosis not specific. So let's look at a couple. Here's one from ultrasound, 5 ultrasounds over 2 years. The mass remained exactly the same. It did not change. It's got a relatively thick wall. There's a little nodule here. It's primarily cystic. A bunch of MRIs, finally, that show T2 weighted images where you can see in multiple T2s that we have this mass, but interestingly, on T2, very low signal. So sort of relatively homogeneous, low T2 signal, appears to clearly lie within the ovary. We see a few follicles around the outside of it, and it has what's known as shading. It has this drop-off of signal towards the center of the lesion. What is shading? What does that buzzword mean to anybody? Diagnosis? Endometrioma, great. But you'd love to see your T1s to confirm it, right? So you have to get T1s because here we have T1 with fat and T1 without fat, and T1 shows us that there's high signal in here that did not suppress. Therefore, it's not a dermoid or teratoma. It is an endometrioma. This is the classic appearance of endometriomas, multilocular, hemorrhagic, blood-filled chocolate cysts from pathology. Remember, that's the buzzword, the way they describe them. And the blood can be of different ages because as the menstrual cycles will cause bleeding in different parts of the lesion on different months or in different parts of the cycle. So it's heterogeneous, it's multilocular. There can be associated adhesions. An important thing to look for in MR or CT, you'll see the bowel loops will be tethered and puckered and angular and spicular around that area. Advanced cases may also have associated adenomyosis. An important thing to look for and an important presenting for pelvic pain. In malignancy, primary adenocarcinoma of the ovary, MR, and then pathology. This is what I want you to think about when we're looking for those nodules on the inside of the cyst, the sort of vegetations, papillary growths that look like this, obviously, in pathology. And here in MR, a very large one, enhances with gadolinium after the injection. Other than that, it looks like a relatively unilocular lesion, right, with a fairly simple-looking wall. So this was clearly the malignant feature and clearly not a benign lesion once you see that much enhancement. Staging of ovarian cancer, as you know, unfortunately, we don't normally see patients in the early stage. The vast majority, even today, still present at stage 3 and 4. But remember, we are trying to pick them up a little bit earlier and earlier if we can by ultrasound and by family history and screening. But the important one is to remember the way this spreads. It's different than almost any other cancer. Cells are shed from the surface of the ovary, and it will spill out, causing malignant ascites. And then it spreads through the pelvis, following the flow of the fluid. And here's one from ultrasound that was picked up early. It was a complex mass. They were concerned about it. We confirmed their suspicions on MR. We have a cystic and solid lesion on T2. It's cystic, high T2 signal, solid back here, as you'll see with the ad in a minute. Septations are thick and they're nodular, so all kinds of bad words. And then you see pre- and post-gadolinium, no evidence of blood. We can't make it an endometrioma, can't make it a dermoid, and so we inject the GAD and we see the contrast enhancement, nodularity on the septations. And this was a primary ovarian neoplasm confined to the ovary, so one of the earliest pickups that we've made. Now, once it starts spreading out into the peritoneum, this is an important part about management of the disease. It's relatively important, first of all, for us to make this diagnosis. And this can be made relatively easy on CT or MR. It's grouped according to the size of the nodules. So do try to measure them. And if you find ones that are greater than 2 centimeters, that's very important. These patients will be treated with chemotherapy before their radical hysterectomy and oophorectomies in an effort to cyto-reduce the disease. And so that's an important piece of information to put in your reports. Don't just say, multiple peritoneal nets. Let's measure them and let's put in some detail in the report. And then obviously as it spreads onwards, interstitial diseases will nodal disease. What do peritoneal implants look like? Well, the first place to look is the cul-de-sac. Because most of us live standing up, and so the fluid goes by gravity, and so it will live in the cul-de-sac first. These deposits fall deep into the pelvis, and so they live in the deep cul-de-sac or adjacent to the bowel. And if we use MRI, we need gadolinium, and we'll pick them up like this, little small deposits that can be either solid or cystic, depending on how long they've been there, but very commonly they'll be cystic, and so rim enhancing like that. They can be hard to see even on CT, and you can see without oral contrast material, you're almost wasting your time, because half the time you can't tell what's bowel and you can't tell what's implant. And is there an implant in there? Well, it was read as negative, there was nothing in there. And there was something in there, excuse me. And we go to MRI in the same patient, and you can see that clearly there's a solid mass sitting on the bowel here. And so I'm not sure that we always need our oral contrast as much as, that MRI, it doesn't have oral contrast, of course, but do we really need it? I think you can see the error, and you can see the mass fairly clearly here, and you can see it after gadolinium. And just in case we don't believe that, we also did PET imaging, and you can see clearly that there's a focal area of uptake of this metastatic ovarian cancer with a large peritoneal implant in the pelvis. So we know how it spreads. It comes out through the ovary and spreads through the fluid pathways. So cul-de-sac first, then up the right side of the colon, along the right paracolic gutter, up around the liver. Look up around the liver first, then it comes down through the omental leaves into the small bowel mesentery. Another example of a patient on CT here. Look for the peritoneal implants. This is a study in the year 2000. You can probably hopefully see those. They can be quite subtle when it's early. Small little soft tissue things here. They're a little bit like salt and pepper studding of the peritoneum. You need IV contrast to find these most of the time. You want to also look for the thickening of the peritoneal surfaces as a tip-off that there's disease. 2 years later, it had grown a little bit more, not a lot, but certainly it had grown quite a bit and was up beyond the 2 centimeter mark. How well do the imaging modalities that we use compare to each other for this disease? Well, first of all, telling benign versus malignant. All three, ultrasound, CT, and MRI, did extremely well in this study that we did with Al Kurtz, Rusty Brown, Stu Silverman, and a bunch of us across the country in a multi-institutional trial. You can see really that all studies with ROC analysis did equally well, telling benign versus malignant disease. Once we start spreading outside the ovary, looking for staging, it's surprisingly MRI, even in those days, which is now, I don't know how long ago this was, it's too long to count probably, but MRI was doing very well, a little bit better than CT, here, because I think MRI had the advantage of multiplanar imaging and was able to see the diaphragm better, so picking up peritoneal implants in that area was an advantage for MRI. Ultrasound did surprisingly well in the upper abdomen too, and so with some dedication and some real attention to that area, when you're really worried about malignancy, you will be able to pick those up at the time of ultrasound as well. Another malignancy that we use MRI for is particularly common is cervical carcinoma, and we use it occasionally to tell whether it's an endometrial or cervical primary, but most of the time they're already biopsied, they're coming in for staging evaluation. And our role is really to tell them how big it is, first of all, because size has become incredibly important in cervical cancer. They will not operate anymore on someone who has a mass greater than 4 centimeters. So your size, and you are the most accurate. And I often tease my residents a little bit when I read the report that says the mass is 3.5 by 4.2 by 3.1 and is approximately these numbers. And we have the word approximately in the report. That's the most accurate measurement there's known to man. I mean, no one else is going to measure it as well as we are. So don't say approximately. That's probably as close. Pathology will probably do it a bit better, maybe. But you're very accurate when you're imaging, so don't use approximately. Much better than we are than physical examination. Size is critical, and CT doesn't do well, obviously, in seeing the cervix and measuring cervical masses, so I wouldn't put a measurement in a CT pelvic report unless I thought I was really able to see the mass. So saying something like this is a 4 centimeter mass is probably a bit of a mistake. When we get to the MRI in the same patient, you can see that there's only a small, little less than 1 centimeter mass here. So beware of sizes on CT, but do be careful and do measure them properly on MRI. And it makes a huge difference. If it's more than 4, it's radiation therapy nowadays, not surgery. Okay, so once we've done size and volume, and volume is incredibly predictive of prognosis nowadays. If the volume is bigger, the prognosis is worse. And so it's very important to do your 3-axis measurements. The radiation oncologists, particularly important for them. As you know, they love measurements like all oncologists, right? So T1 and T2 for staging, advanced disease, complete replacement of the cervix by a large mass here, no normal cervix, no black ring, no donut like we saw early on. It's all tumor. And here on T1, we can see spiculation of the fat surrounding the cervix. This will look the same on CT. You should look for this on CT as well. The ligaments will be infiltrated by tumor, and that's outside the parametrium. That's what's known as stage 2B, that last case. So parametrial extension means that the patient is no longer a candidate for surgical excision. They don't want to cut through the tumor and leave tumor inside. So this patient will go to radiation therapy, as will this one, who also has a smaller lesion sitting here. Multiplanar images will show you it's actually relatively long in the coronal plane. That's an Abotian cyst in the middle, and you can clearly see the invasion out into the parametrial tissue on the right side here. And more advanced disease, clearly lymph node metastasis can be easy to diagnose when they're this big. The reason I show this is to look at the lymph nodes when they're even small and see if the signal intensity matches that of the primary tumor, and it will help you in diagnosing metastasis, perhaps in a micrometastatic mode. That patient, same patient in the sagittal view, showed extensive bladder wall involvement as well. Gadolinium here. This is the sag normal bladder coming down. This is the fundus of the uterus and obstructed endometrial cavity. This is all her hypovascular tumor here, normal cervix at the back, and then you can clearly see the tumor is broken through and is going into the bladder here. So stage 4 disease, definitely not a surgical candidate. Okay, remember that CT I showed you at the beginning? These are a little noisy, but this is the MRI in that same patient. So if you remember that CT that showed a pelvic mass, remember the patient was coming for staging CT, pelvic mass. Question was, is there bladder invasion, is there rectal invasion? The CT was given, IV contrast had been given, not much oral contrast. Now the IV contrast had not made it down into the bladder, so you didn't see the bladder contrast. So let's just look at this now in MRI. You can clearly see, first of all, these are all T2s. No contrast has been given yet. So the inherent contrast material, or the contrast of the tissues on the MRI, shows you immediately what's going on. This lesion lives within the vaginal wall. The thin black line is the stretched vaginal wall around the mass. You can see the bladder wall in front, quite normal, not invaded on this view. You can see the same thing down deep here where we go towards the level of the sphincter. This is the external urethral sphincter here. Again, the mass in the vaginal vault. Sagittal view shows it growing upwards, probably arising here on one of the muscles, and growing up and expanding the vaginal cavity. And then, of course, we like to give gadolinium. And you can see the gadolinium enhancing the lesion, but again showing normal vaginal walls surrounding it. So very important role of multiplanar imaging here. Another one showing the tumor going right down deep onto the level of below the introitus almost, and going out onto the side of the pelvis into the labial area. This was this is a vaginal melanoma, the most unusual lesion. I don't expect the diagnosis to be made. The patient came with that pathological diagnosis. But our role is to stage this lesion and to tell the surgeon what needs to be excised. And so here we were able to say that the bladder is not invaded, the rectum is not invaded, and the sphincter is not invaded. So hopefully she can preserve the urinary function and the rectal function. That's going to be a tricky surgery, there's no doubt, and I don't know if they will be able to do that. This was just to be done this week. But what I want to stress to you here is that when you're dealing with something unusual like this, first of all, MRI is by far the better test to diagnose and to stage these lesions. But you must be careful not to just talk about the mass and the size of it. You must stage it. We must be able to tell them clearly how the bladder wall interface relates, what the rectal wall looks like, what the pelvic side walls look like. Think of what the surgeon needs to know. She doesn't, or he doesn't need you to tell them there's a mass. This is clearly there. And we can spend ages talking about the characterization of the mass and what the tissue looks like and what our diagnosis might be. But to be honest, that's really not what they want us to do. They've done a biopsy. They may even be able to tell you what the tissue is. Staging. Get the multiplanar stuff. Do MRI. Obstetrical imaging, just a little bit before we go into the male pelvis. We're doing this a little bit more and more now. We've always imaged with MRI patients who are pregnant, for maternal causes, placental causes, and now obviously for issues related to the fetus. And why haven't we been doing it forever? Well, obviously initially there were problems because the sequences were too long, baby tends to move, and this was a big problem. But now we're able to do images in about 20 seconds or less and get these snapshot images of this exquisite display of the anatomy of the chest, the diaphragm, the liver, the bladder, and all of the anatomy of the thorax here, nicely seen. Debbie Levine in the Boston area has written a lot about this with applications to CNS anomalies in utero, and Ann Hubbard in the group at CHOP in Philadelphia use this extensively, and particularly in chest disease where they're looking at diaphragmatic hernias. Is it safe? Well, the safety of MRI has not been established according to the FDA in pregnancy, but clearly one standardly screens the patient for the pacemakers and everything else, and then when nothing else can be done, it should be used. It's the next best test after ultrasound. Ultrasound normally can do extremely well, and so this is clearly a second line and is useful as a supportive modality. Some examples of pathologies: intraventricular hemorrhage, clearly seen here. We can somewhat age the hemorrhage on MR by looking at the appearance of the blood and then by following it. This is an early just beginning to develop some sulcation here, about 20 weeks development, and you can see the hemorrhage in the early hydrocephalus. Dandy Walker keyhole deformity in the posterior fossa here, confirmed by MRI, nicely seen there. Congenital diaphragmatic hernias, usually easily diagnosed by ultrasound. The issue is whether or not the liver is in the chest. This is extraordinarily important for the morbidity and mortality of the outcome. If the liver is up in the chest, the mortality rates drop precipitously. Much, much worse prognosis. Is the liver in the chest or not is a difficult question to answer on a patient on ultrasound because you have abnormal lung right beside it, because on this particular one with the hernia on the opposite side, you have that hypoplastic lung beside it. It may look awfully like liver, may be hard to distinguish. On MR you can see the liver quite clearly here. Nice example of the double bubble in the chest here. Complicated things like vena-galen aneurysms obviously can be diagnosed by ultrasound, but the role of MRI is perhaps in conjunction with the interventional neuroradiologists to help them plan the ultimate embolization or occlusion of these vessels. You can do cool things like this and take the data from MR, segment out all the vessels, and basically give them a roadmap before they do their angiogram. And as Pat Burrows from Children said to me on this case, this is so nice because I don't have to worry about the MRI of the baby after it's delivered because they're unstable, they may be on a ventilator, they may be difficult to image. But this was in utero, where basically the baby's in its own ventilator and it's in its own little incubator because it's still in the uterus, of course. So it's a very nice way to image the fetus when it's stable. And just some more images. some complex cases like this one. It's useful in fused livers here in conjoint twins, and you could see that they were fused. One was an acardiac twin, and the other one had normal four-chamber heart. The big question was, are there two biliary systems or are there one? There were two, and the surgeons were able to divide the livers nicely. We were able to do, again, the segmentations and show you the happy outcome of the baby surviving. The less happy story, unfortunately, where a patient presented with multiple episodes of abnormal GI bleeding, blood per rectum, valve cramping during pregnancy, thought to be diverticulitis for a while. Ultrasound saw a mass in the left flank, wasn't sure if it was related to the uterus or the baby. MRI confirmed it was not, and unfortunately it was a large invasive colon cancer going back here into the psoas muscles. Okay, so we're going to change gears for the last 15 minutes or so. And we're going to talk a little bit about the male pelvis. And primarily, the uniquely male disease that we image is, of course, the prostate and prostate cancer. And one of the reasons we use MRI in prostate cancer is, first of all, it's an extremely common disease. We require it because we're doing it for staging purposes primarily. We're beginning to do it more and more for diagnosis and detection of this disease. And if you think you know all about, if you think we've sort of solved the prostate cancer problem, you clearly don't know somebody who's had this disease, because this is an extraordinarily controversial disease. First of all, to diagnose at what age, should we screen, should we not, and then once patients have it, what form of treatment should they have? And believe me, the situation, unfortunately, is going to get worse. And this year, in 203, in 203, not this year, but in 203, some 200,000 cases of prostate cancer were newly diagnosed. By 2015, because of the aging baby boomers, they're anticipating 450,000 cases. So it's going to double. We're going to see twice as much. So if you think we see a lot of prostate cancer issues today, you're going to see, and you and your families and everybody are going to be facing this problem even more. So the aging of the baby boomers is causing lots of trouble for us all. What's the role of imaging? We're all part of the baby boomers. Or maybe not some of you. You're all too young, right? The role of MRI is primarily, as I say, staging patients who have known prostate cancer. And so we're trying to determine how extensive the disease is, what the volume of the disease is, the standard staging thing, in an effort to help select therapy. As I said, the next commonest role, which is an increasing role now, is to make the diagnosis, to see if we can find a tumor, to guide a biopsy, to monitor therapy, and to see its response to radiation, cryotherapy, whatever form of treatment people are using, as I've listed right here. The problem with finding the cancer is becoming very obvious that there are many men who face rising PSAs, repeatedly negative ultrasound-guided biopsies or biopsies of any form, sampling error, and trying to find the small cancer in this relatively small organ is extraordinarily difficult. And so I think targeted biopsies is really an important part of the role that we're going to be playing in the future. So what do we do and how do we image the prostate today? Today we're still using 1.5. We will probably change that to 3 Tesla in the next couple of years, because it seems that 3 Tesla, because of the improvement of signal to noise, combined again with the endorectal coil, will improve our detection and characterization of the disease. But for now it's at 1.5 with an E-coil and that same external coil we use in the female pelvis, be it the diaper or the torso coil. We need a lot of coils because this is a very small area with a lot of critical anatomy. And so we need very high resolution imaging, high spatial resolution. Protocol is very standard stuff, just T2s and T1s at the moment. We're getting into, and I'll show you some examples of a more sophisticated approach using MR spectroscopy, which is definitely going to help us in the detection of focal tumors. Now, what does the normal male pelvis look like on MR? T2-weighted images, axial and sagittal. The prostate has 2 major parts that are visible in imaging. There's the inside and then the bit around the outside. So it's what we call central gland and the peripheral zone. Peripheral zone is the C-shaped white structure here, which is the high signal intensity glandular tissue, the place where approximately 75% of the cancers will start. So this is our kind of primary area of interest, this the PZ. Central gland actually represents 2 areas known as the central zone and the transitional zone. We really can't distinguish those in imaging, and it probably doesn't matter. But this is the area where the BPH, or the benign prostatic hyperplasia, occurs. And the hyperplastic tissues can be in two forms. They'll either be stromal or they'll be glandular. So you get all this heterogeneous stuff, which in my little world, because I look at so many pelvises, looks a little bit like a fibroid. But it's high signal T1 and then low signal T2. It's high signal T1 and T2 and this mixed heterogeneous picture, and that's BPH. The rest of the anatomy of the pelvis can be very nicely seen in the coronal view. You can see the level of the urogenital diaphragm here, where the urethra comes through, becomes the membranous urethra, and then becomes the penile urethra. Here at this level in the coronal plane, we have the cross-section of the pubic bones here. We have the pubic rami. And then right next to it, we're getting into the root of the penis. And so we can see the crurae of the corpora cavernosa and then the corpora spongiosa right here in the middle. The sagittal view, you can just about see the urogenital diaphragm here coming down. And then as we go further out, just so you know what the penoscrotal anatomy looks like on MR as well, I think it's important to appreciate that obviously the corpora cavernosa look a little different than spongiosa. They are surrounded by the so-called tunica albuginea, a very thick black circle that surrounds each of them. It's fairly important when it comes time to staging penile carcinomas to determine whether or not that is invaded by tumor. And you will see that potentially because, as you know, squamous cell carcinomas arising at the meatal level will invade inwards, and they will break through the tunica albuginea into the corpora cavernosa. And that will determine the resection of the procedure and the amount that has to be resected. So we use MRI definitely for staging the penile carcinomas. So let's just talk a little bit more about prostates now. Spectroscopy has been used more and more frequently now. We're in the middle of a large multi-center trial to try to determine how useful it is. But going back quite a ways, this paper was in '96. This is from the group at UCSF, and John Kerhanowitz and Hetty Resek really pioneered most of this work. And you can see clearly there's a big difference between cancer, benign tissue, and dead tissue. So dead tissue is basically flatline. There's no metabolic activity going on in these voxels. This is the pathology correlate. The normal looks like this. The normal prostate has lots of citrate in it. So we have a nice big citrate peak. We have a very small, relatively small choline peak. And all that happens, and it's quite simple really, when you get cancer is you get a complete reversal of those peaks. The citrate drops and the choline comes up. And choline comes up in response to increased cellular membrane, increased cell proliferation, and a couple of other things. It's not a single cellular reflection of a single cellular activity, but simple reversal of those. So citrate goes right down and choline comes up. So it's quite simple to interpret the spectroscopy. What's really hard, or relatively hard, is actually getting the right data. And that's getting a lot easier, actually. Of course, it would be really cool if they all came out of the computer looking like this, where you'd have this nice color-coded picture which tells you that red is hot and red is bad and red is cancer. But we don't read in color. But this is what they do at UCSF, and they demonstrate the cancer very nicely here. This is the way the data is acquired. And your technologists need to learn where to place this grid, and once they figure that part out, it's actually relatively straightforward. One of the things that's important is to try to avoid contamination by air or contamination by fat around the prostate itself, and you want your voxels clearly to be centered on the gland. And then you simply analyze the spectra from each of those little boxes. I'm going to show you a clinical case in a few minutes, but let's just go back to what T2 does for us. T2 weighted images will show us the focal lesion. It looks like this. Cancer in the prostate, unlike most everywhere else in the body, has low signal intensity. Most everywhere else in the body, like that one that I showed you, that melanoma or the cervical cancer, are high T2 signal because they've broken down their extracellular membranes and they've got lots of water in them, so they tend to be high T2 signal. But this is atypical. It's going to be low signal intensity, most commonly a discrete mass. And one thing about prostate cancer is it's never unifocal. It's almost always multifocal. About 70% of the time, they're little tiny foci that are all over the place. So we're not going to find probably all the cancers in everybody. But the index lesion, as I call it, or the dominant lesion, is the one you should find. And then after that, you stage the lesion. You want to go through your staging algorithm, and every report should talk about whether the capsule's involved or not, whether the neurovascular bundles are invaded, seminal vesicles, nodes, and bones. And this is, if you put all of these in the report, you'll keep those surgeons and radiation oncologists happy. The other critical thing, again, just like in the cervix, is measure the volume. They really need to know the volume. The prostate volumes can range from 30 cc's to 200 cc's. Management of those patients can be quite different. The BPH can make the gland extremely difficult to treat. and if it's big, it's complicated, so you need to measure them. Tumors can be diffuse as well. They can be like this guy here on the left, where it's all the way through the left gland, and it's normal over here. Hemorrhage will occur after biopsy. Biopsies are performed with 18-gauge guns. The standard today is approximately 6 cores, but there are people all over the country doing huge numbers of biopsy cores in this effort to sample the gland and to get the diagnosis. And there's a guy in Florida who takes 80 cores occasionally. I mean, that's a prostatectomy. But the guy actually walks out of there without a prostatectomy. But, so there's an extreme range, and obviously you're going to be left with hemorrhage after a biopsy. The more typical in the conservative Northeast is about 6 to 12 cores. Hemorrhage will cause high signal. Hemorrhage can fake you out in T2 and make you think it's the tumor. Be careful of that. Get your T1s to match, and you won't make that mistake. This is the tumor. There's no matching hemorrhage over here. That's our lesion. Again, remember, it's not really about diagnosing the cancer in those cases. It's staging the cancer. So here's a patient that recently had that came to us recently 4 years after seed implantation. And seed implantation is one of the most popular therapies right now, where these little radiation sources, like a grain of rice, so to speak, are placed in the prostate percutaneously, transperineally, and they cause local radiation ablation. This guy, unfortunately, his PSA started to go back up after 4 years. We did some MR imaging at endorectal coil here, and you can see the prostate just about on the T2 images. What happens after radiation is that the whole gland goes dark. The signal just drops down because the radiation fibrosis induces this drop in signal. And so we have a hard time finding that focal low signal lesion that we just spoke about. So here's a place where spectroscopy was extraordinarily helpful. And so here's our grid. We put our boxes on. And over here, you may have only ever seen one abnormal spectra in your entire lives, because it's the slide I showed you 3 minutes ago, right? So look at these carefully and see if you can see anything abnormal. So back here we see a lot of noisy stuff, a bit more noisy stuff. But look at these guys up here. Now the boxes correspond directly to where they are. So 3 rows, right? So up here, very abnormal, and that's up here. That's a really strange place to get prostate cancer. Because anatomically, that's where a thing called a fibromuscular stroma is. They're not even supposed to be glands up there. So we thought, that's really weird, that doesn't make a lot of sense, but this is clearly abnormal, we better worry about this a little bit. So what we decided to do then was to do a biopsy, and we have a system now where we can do MR-guided biopsies. And until now, we've been doing T2-guided biopsies. But in this particular case, we were able to do a spectroscopic guided biopsy. And we have some smart computer scientists to work with us who can do a lot of nice things with registration of data. And this is the T2 image fused onto the real-time image at the time of the biopsy. And there's the spectroscopic abnormality to guide me into where I should put the needle. And then we put the needle up there, way up there, which is not a place that I would ever sample normally, nor with any urologist. Go all the way up in front of the urethra to biopsy the prostate and find this recurrent disease. And so this is where his adenocarcinoma had either recurred or was residually there from the original therapy. And so we were then able to re-implant this patient and do what's known as salvage brachytherapy, where you place the seeds back in again, and now we place them all the way up here in an effort to control his tumor locally. So spectroscopy, I think, is showing some major clinical applications. So what do we do in staging now? Talk about extraglandular disease. How do we diagnose it? Direct extension is the easy one. Tiny little focal angular bulges, thickening, central invasion, NBV, same thing. And SV is a little easier to diagnose, as I'll show you in a second. Tumors that bother us are ones that are down deep at the apex. Remember, this is an inverted pyramid. The apex is towards the feet. The 5 and 7 o'clock location are diffuse tumors. You've seen this case a minute ago. This is now a better view of it. You can see clearly extracapsular disease. It's going past the capsule. You can almost see a ghost of a capsule through here. You can see the counterpart over there. They usually are relatively symmetric. If there isn't a lot of BPH, then they should look the same on either side. This does not. It's invading out. Sagittal view, extremely helpful here too, to confirm that. And 2 or 3 planes is really useful. Sometimes, inevitably, kind of Murphy's Law, one of them won't work, or one of them doesn't come out right, or the patient moved, or there was a wave of peristalsis right through the area that you wanted to look at. And so having the 3 views is really very valuable. So you can see the extracapsular disease there. Another example with tiny focal bulges here, diffuse tumor, pretty bad numbers. I like to get these numbers when we're interpreting the study. I don't really believe in interpreting this stuff without that information. All my residents are smiling. They know. We constantly trying to get this stuff out of the computers. So the Gleason of 7 and a PSA of 19, very bad numbers, unfortunately, already. So yes, I'm somewhat biased when I look at the images, but I put this all in the report. I think it's the smart thing to do for the patients. So we can see clearly here that these little bulges are very suspicious, particularly in view of these bad numbers. Seminal vesicle invasion is much easier to diagnose. You can see diffuse low signal intensity replacing the normal fluid-filled tubular structures, which normally kind of look like bunches of grapes or lots of little cysts on either side. This is tumor growing upwards here in a 49-year-old man with a normal PSA and a rock-hard prostate, and he had Gleason 9 on both sides. Another patient here who has diffuse abnormal disease, a pretty poor quality study because we've got a lot of motion here, but you can clearly see in the coronal plane, it really doesn't matter whether we see capsular extension or not. This is much more advanced. There's bilateral seminal vesicle invasion. So unfortunately, this is still a problem. And people say to me, well, you can stage these clinically. Well, you can't. This number really hasn't changed in all the years that I've been working in this area. A lot of patients are going to surgery who have extracapsular disease, who really shouldn't be having surgery. Surgery is not without its morbidity, such as incontinence, impotence, and sexual, say, after surgery. So this is a real problem. Same thing with radiation therapy, which has the added GI side effects of radiation toxicity to the rectum. So we really do need to make an effort to try to improve this. There are some men that really need MRI. They fall into this intermediate group where PSA and Gleason will not stage them accurately. They're the ones with these indeterminate numbers, where the numbers will not predict whether it's advanced or not. MR, it can be useful. There's a definite learning curve to doing this. Lots of studies showing that over the years. We've got some good features now, and I think we understand it well. Lymph node disease is rare in our population, but we do always look for it. The patients that we tend to see tend to be early disease. We are currently still using size and location as our way of detecting lymph nodes, but you may or may not have heard there is a new contrast agent called Combidex, or a small iron-containing agent, which is injected intravenously to do so-called MR lymphangiography. And I think that's going to help us in these more advanced diseases and more patients who perhaps have recurred or failed other therapies, where we're looking for abnormal lymph nodes outside the pelvis or elsewhere, and not just in prostate cancer, but obviously in anything. So really, to summarize, in prostate, I think the role is in this intermediate group. We're pretty commonly see extracapsular disease. Helps patients themselves. Patients are very savvy. They're out there looking for as much help as possible in making this treatment decision, and it's obviously very helpful before and after chemotherapy. And in conclusion to everything, I hope you appreciate that in female pelvis, the MRI role is expanding. We have some new places where we're using it, and certainly spectroscopy is helping us in MR, the prostate, to make more and more clinical decisions. So I thank you for your attention. And we'll have a break now until 3:30.